Good to see everybody today. Since it's 12:15 and we've got a lot of ground to cover, we're going to go ahead and get started. I'm Carrie Perry, president this year of Georgia OBGyn Society, and I want to welcome everybody. This is a great turnout. I'm very excited that you're all here for our resident poster presentation session today. Today's lectures will feature a poster presentation from residents from each of the residency programs in Georgia. The poster presentation has been an integral part of the Society's annual meeting, and this year we're pleased to bring it to you virtually. Dr. Roland Matthews, Professor and Chair of the Department of Obstetrics and Gynecology for Morehouse School of Medicine, and our very own Chair of our Education Committee, will be facilitating today's webinar. I'm going to pause here just to remind everyone of a few items of the important business. If been with us before, you've heard some of this, so bear with me. First, please take a moment to mute yourselves. Make sure your microphones are muted. We will try to get time for everyone at the end to have time for questions and comments, and we'll do our very best to get to you, but just stay muted for the entirety of the program. Next, we're hopeful that time will allow audience members to ask our residents a few questions, and to do so, you should utilize your chat feature and enter your question into the chat box. We're going to be monitoring that chat box at the headquarters. If we don't have time to get to the audience Q&A portion of our program today, what we plan on doing is making a list of each and every question, making sure we facilitate answering along with the residents who give that presentation, and we'll get back to you over the course of the next week. Please make sure to put your email address in with your question so that we can facilitate that. Today's lecture is being recorded and it'll be offered later on demand. So if you don't get a chance to attend all of today's session, or if you have to step out for a moment and you get interrupted, you can always go back and see this great content later. Now that we've taken care of that, I'm very pleased to welcome Dr. Roland Matthews, who will provide an overview of today's program and introduce our resident speakers. One note I'd like to mention is that, as I said, we have a presentation today from each of our 6 residency programs. At the time of his message, we only had 5 of those tapings submitted. We now have all 6. So he may say 5, but stay tuned. We're going to have 6 presentations today. So thank you, Dr. Matthews.
Thank you, and good afternoon to everyone here supporting our residents. Again, welcome to the Georgia Obstetrics and Gynecology Society's annual residence program presentations. First, I would like to thank the Society's leadership
Good morning.
for their commitment and dedication to ensuring this annual program happens this year. Specifically, our past and current presidents, Dr. Coxty and Dr. Perry, for their leadership in recognizing the importance of this program by allowing the residents to have a forum to present their work. I also would like to thank the academic committee and the GOGS staff for their assistance in organizing this event.
Sounds that way.
We have had 6 abstract submissions, and today we will have 5 residents give oral presentations. Residents will present their abstracts at the end of all the presentations. Our judges will ask questions of the presenters. And if there is time, we will have additional questions from the audience. Thank you, Dr. Nutalapati and SPAN, for agreeing to be our judges for this program. The winners of this year's program abstract presentation will be announced in the December issue of the GOGS newsletter. Everyone, please take a moment to make sure that your microphones are muted. We are asking that they remain muted throughout the presentation. Additionally, you can use the chat feature to enter any questions. Please specify which speaker you would like your questions directed to. Alternatively, you can press the raise hand feature and be recognized if you would like to ask your question in person. Now, we will proceed with our 5 abstract presentations in alphabetical order by program. Our first presenter is Dr. Winsworth from Emory University, followed by Dr. Romero Del Melosa from Medical College of Georgia, then Dr. Graham and Collado from Mercer University School of Medicine, Dr. Garrett from Morehouse School of Medicine, and finally, Dr. Stone and Tricard from Wellstar Kenneth Stone Hospital.
Hello, my name is Caroline Wentworth, and I'm a PGY3 resident at Emory University. I'll be presenting my research project, Composite Adnexal Torsion Prediction Score, Evaluation of a Quality Improvement Tool in Pediatric and Adolescent Gynecology. I'm grateful to be working with Dr. Krista Childress as my research mentor. As we know, adnexal torsion can have a nonspecific presentation, including lower abdominal pain and nausea and vomiting. This can make it challenging to distinguish this diagnosis from other similar diagnoses that a patient may present to the emergency department with. Importantly, there is no definitive clinical or radiologic test to diagnose torsion. Definitive diagnosis is only by surgical exploration, which can then lead to subsequent surgical management. Girls with torsion need to be accurately identified as such in order to make sure that they get the appropriate surgical interventions that can prevent the long-term consequences of torsion, including loss of a tube or an ovary, which can have long-term health implications and fertility impact. It's also really important for us to be able to accurately identify girls without torsion so that we're not operating on girls who don't need it. Though gynecologists are often quite adept at making these diagnostic decisions and determining who needs to go to an operating room, there are often not pediatric and adolescent gynecologists available to help with this decision-making when pediatric and adolescent patients present to children's hospitals with these complaints. Algorithms have been found to be valuable tools to assist emergency departments in deciding which patients need surgery for similar types of complaints, including, notably, appendicitis. A recent study out of Cincinnati prospectively evaluated factors previously determined to be related to ovarian torsion amongst girls presenting to the emergency department with a complaint of abdominal pain. They found 3 factors that were predictive of surgically diagnosed torsion. These were vomiting, adnexal volume of the affected ovary, and affected to unaffected adnexal volume ratio. These factors were assigned point values, and each patient then received a composite score. Each factor earned a patient 0 to 2 points, and overall they had a composite score of 0 to 6. Amongst the cohort of 324 girls, there was a less than 3% risk of torsion with a score of 0 to 1, a 3 to 10% risk for girls with a score of 2 to 3, and a greater than 25% risk of torsion for those with a score greater than 4. In sum, lower scores denoted low risk of torsion, with increasing point values corresponding to increased risk. This study suggests that a clinical algorithm could be created to help triage patients and decide who needs exploratory surgery. However, no published research has yet validated these findings outside of this original study cohort. Our research, which is based on this Cincinnati study, has the potential to advance the previously developed CAT score into a clinically useful tool. It takes these previously developed criteria and uses them in a new cohort to determine if this is a valuable tool to use in clinical practice. Significant findings from this research could signal a paradigm shift in the diagnosis of adnexal torsion, away from inconsistent and vague clinical gestalt towards a clear risk stratification algorithm with the potential to improve outcomes. This tool would allow for standardization of management, and this could also lead to greater equity in the quality of care. The methods for the first arm of our study are below, and the distinguishing features for each arm, which I'll get into later, are found in red. The first arm of the study is a cohort study of girls under the age of 21 who underwent surgery between 2016 and 2020 with concern for torsion documented in their note or operative record, or a CPT code denoting torsion. They were excluded if no ultrasound was done or if data were incomplete to calculate a CAT score. Each chart was then assigned a score of 0 to 6, as previously discussed with our version of the CAT score. A chi-squared analysis was then done to determine if the composite score and secondarily its subcomponents were predictive of torsion. Thus far, we have data for Arm 1, which can be seen on this slide. Demographic data are at the top left, including the average age and menarchal status of our patients. It also shows the average score of our patients and the overall rate of ovarian torsion. At the bottom left, we see how many patients had torsion by score, separated into premenarchal and menarchal girls. The graph on the right shows these numbers in visual form, bucketed into scores of 0 to 1, 2 to 3, and 4 or greater, as done in the Cincinnati study. As you can see, higher scores were associated with higher rates of torsion. When comparing girls with scores of 4 to 6 with those of scores of 0 to 1, the overall composite score was a significant predictor of adnexal torsion. The odds of being torsed with a high score were 6.4 times the odds of being torsed with a low score. Presence of nausea and vomiting were also found to be independent predictors of torsion. Adnexal ratio and adnexal volume were not found to be significant predictors in their own right. These results support the statistical significance of the CAT score in a cohort with a definitive surgical diagnosis. An additional strength of this arm of the research is the robust sample size. Despite these strengths, Arm 1 alone is not sufficient to support our hypothesis. The overall very high rate of torsion in this cohort at 93% is not representative of the circumstances in which this score would be used in true clinical context. This high torsion rate is likely a result of selection bias, whereby the only participants are ones who had symptoms significant enough to require operative management, resulting in low scores being insufficient to rule out torsion. This limits the clinical significance of our score. In order to truly assess clinical utility, an evaluation of all comers with abdominal pelvic pain is needed. Arms 2 and 3 of our study will address this by focusing on the clinical use case of girls in the emergency department with abdominal pelvic pain, regardless of how they are eventually managed. Additionally, Arm 3 will include data on incorporating the CAT score into clinical practice for further evaluation of the clinical utility of the score. Arms 2 and 3 are detailed here, Arm 2 on the left and Arm 3 on the right. This includes both a retrospective cohort study and a multi-center prospective cohort study and implementation analysis. To avoid selection bias, our new retrospective cohort study will pull from all comers with abdominal pelvic pain presenting to the emergency department, in contrast to our previous study of only surgically managed patients. Additionally, we have our multi-center prospective cohort study that will implement the use of a smart phrase in the electronic medical record, which will allow emergency room and surgical providers to implement the score in their clinical practice and use it to help make management decisions moving forward. I would like to take a moment to thank the people that I've worked on this project with, including most notably Dr. Childress, my research mentor, as well as our numerous interdepartmental collaborators from emergency medicine, radiology, pediatric surgery, and of course, obstetrics and gynecology. Thank you so much for your time.
Good afternoon. My name is Sue Ellen Romero de Melosa. I am one of the third-year obstetrics and gynecology residents at the Medical College of Georgia in Augusta, Georgia. Today I'm presenting my research, which is titled A Smartphone-Based Application to Improve Breastfeeding Rates and Self-Efficacy, a Randomized Controlled Clinical Trial. A little bit of an introduction on this topic. There are several benefits of breastfeeding that are well documented for both the mother and the neonate. Benefits for the mother includes decreased risk of hypertension, type 2 diabetes, ovarian cancer, and breast cancer later on in life. Benefits for the neonate includes decreased risk of asthma, obesity, severe lower respiratory disease, sudden infant death syndrome, otitis media, GI illness, and necrotizing enterocolitis. Breastfeeding duration remains suboptimal despite these well-known benefits. The recommended duration of exclusive breastfeeding is 6 months. However, only 58% of mothers are still breastfeeding at 6 months. Even less, only 25% of mothers are exclusively breastfeeding at 6 months. There are several well-identified modifiable factors that can influence a mother's decision to continue breastfeeding. This includes breastfeeding knowledge, self-efficacy, and confidence. Self-efficacy can be measured using the breastfeeding self-efficacy scale, which has been positively correlated with breastfeeding duration. A little background on the current study. There are current apps out in both the Apple Store and Android Store for breastfeeding mothers. These apps currently are mostly for tracking feeds and pumps. There are a few apps for finding public breastfeeding places and a few apps with resources and general information for mothers. Smartphone apps are still needed that provide information about the health benefits of breastfeeding, counter misperceptions and negative perceptions of breastfeeding, and that explain successful techniques and provide motivation. High-quality, research-tested apps could provide a useful and low-cost way to disseminate information about the benefits of breastfeeding to patients. Our present study is based on an app that we've created. We created this as a resource that is easily accessible in the form of a free Apple application called Breastfeeding at AU. It was created using information, videos, and infographics with permission from several sources. The hypothesis of this study is that the app will improve breastfeeding self-efficacy, duration, and intention to continue breastfeeding at 6 weeks postpartum. The primary objective is the change in breastfeeding self-efficacy at 6 weeks postpartum compared to immediately postpartum. Secondary objectives include exclusive breastfeeding percentage at 6 weeks postpartum, total duration of breastfeeding, and the intention to continue breastfeeding at 6 weeks postpartum. This slide just shows 3 screenshots from our app. The first screenshot shows that it has good, useful information about the benefits of breastfeeding and why a mother should breastfeed. There's pictures and videos that the patient can watch. It also then goes into detail about how to breastfeed, how to have a baby latch appropriately, and how to ensure that the baby is feeding sufficiently. Though not listed on this slide, the app also contains good information regarding pumping and how to properly go about doing that, along with storing breast milk and how long stored breast milk is good for. And then it also has a section on frequently asked questions that the patients can review for any questions that they may have that is easily answered there. An additional benefit of the app that is also not listed on this slide is that it contains information about how to get in contact with our lactation consultants at our hospital, but also how to find lactation consultants closer to the patient's home. Methods of the current study. Inclusion criteria were women delivering at Augusta University Medical Center between March and May of 2020 who were greater than or equal to 37 weeks gestation. They also had to have an iPhone or an iPad with internet connection, since our app is currently only available on the iPhone and iPad store. The exclusion criteria were infants or mothers who got admitted to the ICU, infants with palate/facial defects, mothers with abnormalities of the chest, mothers unable to breastfeed secondary to communicable illness or toxic medication, such as mothers who were HIV positive, mothers of infants up for adoption, and non-English speakers. The breakdown of the participants is as follows. A total of 156 mothers were eligible to participate in the study. 116 declined participation, and we included a total of 40 participants. They were randomly allocated to their groups, and 20 ended up in the intervention group and 20 in the control group. An initial survey was given immediately postpartum within the first week after delivery. And then we also did follow-up surveys 4 to 6 weeks postpartum to see how those mothers were doing. Within the intervention group, 3 women were lost to follow-up and 17 women ended up being analyzed in the study. And then within the control group, 1 woman was lost to follow-up and 19 ended up being analyzed from the control group. This slide contains an example of what our surveys looked like at the 6-week follow-up. The first page contains the breastfeeding self-efficacy short form, which we used with permission from Dr. Cindy Lee Dennis, the creator of this form. It contains 14 questions about the patient's confidence in each of these things on a scale from 1 to 5, 5 being very confident, 1 not at all confident. It asks questions such as, I can always determine that my baby is getting enough breast milk. I can always breastfeed on my baby without using formula as a supplement, and so on and so forth. The second part of the survey includes demographic information, whether the pregnancy was planned, mode of delivery, total duration of breastfeeding, the breastfeeding exclusivity, plan to continue breastfeeding, as well as a section to provide feedback regarding the app. Our data analyses were performed as follows. The categorical variables were summarized using frequencies and percentages. Fisher's exact test was used for the group comparisons. Our continuous variables were summarized using the mean plus or minus the standard deviation. They were tested for normality using the Shapiro-Wilkes test, and then the t-test or the Mann-Whitney-Wilcoxon test was used depending on the normality results. SPSS software was used for the data analyses, and all tests were two-tailed with a significance level of 0.05. This slide shows all of our results. As a side note, the demographic data for the groups were all statistically similar. And then the change in breastfeeding self-efficacy at 6 weeks was our primary objective, and that was found to be statistically significant as our intervention group had a significant improvement in their self-efficacy as noted here on the top left. The control group had a small increase in their self-efficacy, but not quite as drastic. Then we looked at our secondary objectives, and the exclusive breastfeeding rates at 6 weeks was higher for the intervention group that utilized the app compared to the control group. However, this value was just over our statistically significant p-value of 0.05. And then we also evaluated the total duration of breastfeeding. Our patients in the intervention group breastfed for approximately 5.1 weeks compared to 4.8 weeks in the control group. This value was not statistically different. And then the final thing we asked the patients about was the intention to continue breastfeeding at 6 weeks, and the intention in the intervention group was higher at 94% compared to 84% in the control group. However, this value was also not statistically significant. In conclusion, this pilot pilot study demonstrated that women who received immediate postpartum access to a novel Apple breastfeeding app had improvement breastfeeding self-efficacy at 4 to 6 weeks postpartum compared to women who received usual care alone. The limitations of the current study included that the researchers were not blinded, the small sample size, the short duration of follow-up, and that the app is only available for Apple users. The future study that we are currently also working on will introduce the app in the 3rd trimester and follow a larger sample of women to 6 months postpartum. The primary outcome for this follow-up study will be the percentage of mothers continuing to breastfeed at the follow-up. The secondary outcome will be the change in breastfeeding self-efficacy score. This follow-up randomized control trial was recently approved by the Augusta University Medical Center IRB, and enrollment has already started. This is the page of all the references that were used for this presentation. Thank you so very much for your time this afternoon.
My name is Sydney Kelledo. I'm a 4th-year OBGyn resident at Atrium Health Navicent at Mercer University School of Medicine. I'll be presenting along with Dr. Ayana Graham, who is also a resident at the same program, and we will be presenting on evaluation of the remaining ovary after unilateral oophorectomy in females ages 0 to 40 years old. We would like to thank Dr. Eunice, our statistician, and our mentor, Dr. Sakari. We will start with some background information regarding unilateral oophorectomies. Not surprisingly, unilateral oophorectomy is not uncommon among premenopausal women. This is presumably due to the fact that there is cardiovascular benefits of keeping ovaries in women less than 65 years old. Specifically, in a 2014 literature review that detailed trends of unilateral oophorectomies over the past 58 years, it was noted that the incidence of unilateral oophorectomy was higher than the incidence of bilateral oophorectomy through age 39. Some common ovarian pathology that would result in unilateral oophorectomy include childhood neoplasms, endometriosis, or torsion with necrosis. The concept of evaluating ovarian volume after unilateral oophorectomy is not new. In fact, there have been animal studies, testicular studies, as well as studies in women undergoing IVF and the pediatric and adolescent population that have all shown that there is an ovarian compensatory hypertrophy following unilateral oophorectomy, also known as an increase in ovarian volume following the unilateral oophorectomy. However, there is still limited definitive evidence for compensatory hypertrophy of the remaining ovary after unilateral oophorectomy, and further studies are needed. Specifically, in our study, whether these differences are associated with the laterality of the remaining ovary was a question, as this has not yet been studied at all. In order to do this, we started by needing a comparison of age normative values, in which we used this paper here by Cohen et al. It was a paper that showed normative mean ovarian volumes by decade of life that we used as a direct comparison for our data. As you can see here reflected in the first 4 decades of life, they clearly lineated a mean volume in cubic centimeters for each decade that we could use as a direct comparison. In order to obtain their values, they used the formula for ellipse, which is 0.523 by length by width by thickness, to calculate their ovarian volume. They had 762 adnexa which were examined, making it a strong comparison. Our primary objective of this study was to examine the volumes of the remaining ovary in post-unilateral oophorectomy patients and compare them to normative ovarian volumes established for their respective age. Our hypothesis was that ovarian compensatory hypertrophy occurs in the remaining ovary after unilateral oophorectomy. Our secondary objectives were to examine the laterality of the oophorectomy, as this had not yet been studied, and also to compare the mean volumes of the remaining ovary based on laterality. Our study is a retrospective chart review performed at the Medical Center Navicent Health using their electronic medical record system to search for diagnostic codes from January to 2011 to December 2020 regarding unilateral oophorectomy. We had specific inclusion criteria, which included women aged 0 to 40 years, and they must have had an ultrasound following their unilateral oophorectomy, and that ultrasound must have been 3-dimensional and/or had ovarian volume reported on the ultrasound report. Additionally, they were not allowed to have any mass or cyst found on this ultrasound. However, we did include follicles which were less than 3 centimeters due to them being physiological cysts. The date of the unilateral oophorectomy and the ultrasound must have also been documented. Again, we used the formula for ovarian volume mentioned previously of 0.523 by length by width by thickness to perform our calculations, and all measurements were obtained by ultrasound and all other imaging modalities were excluded. Our chart review is used to obtain data regarding unilateral oophorectomy date, age at UO, ovarian volume, etc. These findings were then compared to age normative values as published by Cohen et al. Previously mentioned. A statistical analysis was then performed on the resulting data using SPSS.
Searching for patients between ages 0 and 40 years old by ICD and CPT codes of interest yielded an N of 129. Of these 129, 35 were removed because they did not have an ultrasound available after their oophorectomy. Of the 94 remaining at that point, 7 of them lacked one or more of the 3-dimensional measurements of the ovary on ultrasound and were also removed. Of the 87 remaining at that point, 24 had a mass or a cyst greater than 3 centimeters present on the remaining ovary and were also removed from the study. Of the 63 remaining at that point, 3 had an unknown time interval between the time of their oophorectomy and the time of their post-oophorectomy ultrasound and were excluded from the study. This ultimately left us with an N of 60 patients. The table on the upper left demonstrates the mean ovarian volumes by decade found in both our study of patients with unilateral oophorectomies and in the Cohen et al. Study of patients who had bilateral ovaries still present. Our study found a statistically significant difference only in the 3rd and 4th decades of life, such that these patients who had had a unilateral oophorectomy often had much larger ovaries than their age-appropriate counterparts. The table on the right demonstrates the most common indications for unilateral oophorectomy found in our study. The indication was found by examining operative reports and pathology reports, and the most common indications for unilateral oophorectomy were ultimately physiologic cysts, granulosa cell tumors, pain, and ovarian torsion. Our study concludes that there is no statistically significant difference in the mean ovarian volume in patients who have had a unilateral oophorectomy as compared with those who have not when compared in the 1st and 2nd decades of life. However, the remaining ovary in post-UO patients may undergo some hypertrophy, as there was a statistically significant difference in the mean ovarian volumes in these groups when compared in the 3rd and 4th decades of life. Overall, laterality does not appear to impact ovarian volume, as the mean left ovarian volume was not statistically significantly different from the mean right ovarian volume in patients who had undergone a unilateral oophorectomy. The left and right ovaries do appear to be removed at similar rates. There was an N of 30 in the group of patients with only the left ovary remaining, and an N of 30 for the group of patients with only the right ovary remaining. The study also concluded it's important to understand that there may be a difference in ovarian volume after unilateral oophorectomy. May change the threshold for volumes used to evaluate for potential pathology. It can assist in protection of the remaining ovary in patients who have had a unilateral oophorectomy, as there may be an understanding that the volumes may be different. And it can assist in more detailed classification of the past medical history of unilateral oophorectomy, such as inclusion. Studies included directly comparable to the larger Cohen et al. Study, which used the same calculation for ovarian volume, as well as similar exclusion criteria. Additionally, our study population was evenly distributed in terms of laterality of the remaining ovary in UO patients. Our study's limitations definitely included its size with an N of 60, as well as potential confounding factors such as differing ultrasonographers, differing machines, and differing radiologists reading the pelvic ultrasounds. Our studies also likely included differing populations, as they were carried out in different cities and in different times, with the Cohen study taking place in the 90s and ours taking place in the current day. This study presents several other areas for future investigation, including assessment of ovarian function in addition to ovarian size. For example, future studies may be prospective in nature and evaluate serum AMH, FSH, LH and estradiol levels, as well as consideration of the menstrual phase at various time intervals following a unilateral oophorectomy. Other studies may evaluate the rate and patterns of hypertrophy to establish normative values for those who only have one ovary status post-UO. Either way, given the frequency and the range of reasons for unilateral oophorectomy, the study deserves further investigation.
Good morning. My name is Peyton Garrett. I'm a PGY3 OBGyn resident at Morehouse School of Medicine, and today I have the pleasure of presenting to you on disparities in the trends in contraceptive use before and after the Affordable Care Act, specifically looking at the years 2006 to 2019. I would like to take this opportunity to thank the co-authors of this research for their hard work, their contribution from data analysis to data collection. I'm just very grateful and thankful for them for allowing me to also be here to present to you today. So a brief introduction. Birth control use is a common preventative measure that is utilized by women, not just here in the United States, but around the world. And many times in the past, it's been extremely costly for women, specifically looking at the years prior to the Affordable Care Act. Before the Affordable Care Act, we can see that the cost over $1,000 for insertion. And we could see that even common birth control methods like oral contraceptives could cost over $50 for one pack each month. And those were extreme costs to women, out-of-pocket costs to women. And so when the birth control mandate in 2011 was signed in conjunction with the ACA, it required these insurance companies to cover contraceptive methods in their counseling. And through insurance companies' coverage over these contraceptives, we've seen the out-of-pocket costs for women decline significantly. One study in 2018 showed that the out-of-pocket costs declined from 21% to 3%. And even a study in 2015 showed that approximately $1.4 billion annually were saved in out-of-pocket costs for women as it pertained to birth control medications, emergency contraception, and just other contraceptive costs. So the objective for our study was to examine the trends in contraceptive use among women from the years 2006 to 2019 again, to assess if those trends shifted after the Affordable Care Act implemented in 2010. So for our methods, for data, we use the National Survey of Family Growth data. And again, looking at the years 2006 to 2019, we used various analyses to analyze the data, from descriptive statistics to various logistic regression models. And from that, we get these beautiful results. This particular table is looking at contraceptive use here and shifts in the use over the years. And here you can see highlighted the p-values that were deemed significant. In this table, we look at the various demographics of the population that was sampled and their shifts in use over the years. And lastly, we look at a table that looks at the association between the demographics studied or surveyed and the various contraceptive methods that were used. And so to bring all those results and that data together in one beautiful graph, here you can see that contraceptive methods like birth control pill use declined after the Affordable Care Act was implemented, but more long-term, long-acting contraceptive methods like female sterilization increased, as well as LARC use increased. And we can see less effective options like condom use also declined. So to hone in and talk a little more about those results, we saw the largest increase in LARC use, whether it be IUD insertion or implant. And we saw that increase from 7% use to 18%, mainly in the age range of 30 to 44. And of note, it was amongst women of all educational backgrounds. We saw a moderate increase in female sterilization from 25% to 27%. We saw the largest decrease in contraceptive pill use from 27% to 21%. And of note, women 20 to 29 are still the highest users, particularly those women who don't have a partner and who aren't living with a partner. And we also a large decline in least effective options like patch ring injectables, and they decreased by a rate of 2 percentage points. Coital methods like condom use also saw a moderate decline from about 18% to 14%. So what is that really telling us? It's looking like women, because of access to free and affordable contraceptive options, are starting to pursue more long-acting, whether it be reversible or non-reversible sterilization options. And what does long-acting reversible contraception do for us, and how does that really play a role in our patient population and what we do? Well, if you don't know, many of you might, over 3 million unplanned pregnancies occur annually in the United States. And about half of those women, 1.5 million, undergo induced abortion for these unwanted pregnancies. And it's important to note that many times these unintended, unwanted, unplanned pregnancies occur amongst minority races and women with less education. And I point that out to say is that when you have policy and legislation that implements affordable care for not just women who have a high education or women who attain this certain socioeconomic status, but really give a level playing field for every woman to have access to affordable preventative options, you can decrease the rate of unintended pregnancies and decrease the rate of abortions occurring. And when you look at the United States, you have over almost 600 to 700 deaths as it pertains to pregnancies each year. And when you can decrease the risk of unintended pregnancies, you can also address morbidity and mortality rates as it pertains to women in pregnancy. And so just to further that point, and looking at this Shepherd study performed in Colorado in 2018, by allowing women access to affordable, long-acting reversible methods like the IUD, they saw a significant decrease in the percentage of women undergoing abortion. Women ages 15 to 19, they saw a significant fall at 48%. And they also saw a significant fall, 18%, in women ages 20 to 24. And really, the mainstay, the most important point here is when you afford women free and affordable access to preventative medications like birth control or contraception, you allow them the autonomy to decide when, where, how they become pregnant. You can decrease the rate of unintended pregnancies, and you can decrease the rates of abortions, all in hopes of addressing the increased rate of morbidity and mortality as it pertains to our patient population. Thank you. These are my references.
My name is Ansley Stone. I'm a PGY4 at Wellstar Kennestone Hospital, OBGyn Residency Program.
And I'm Lindsay Threlkeld, a PGY3, also at Wellstar Kennestone.
Today we will be presenting a case report of an IUFD secondary to severe preeclampsia complicated by placental abruption and DIC in the setting of COVID. We will also be discussing how vascular changes in COVID can instigate a severe preeclampsia-like syndrome.
Our patient was a 26-year-old G2 P0010 who presented to an outside hospital at 29 weeks for acute onset lower abdominal pain. Her pregnancy was complicated by class 1 obesity, but otherwise routine with regular prenatal care. The patient was found to have an intrauterine fetal demise and be an evolving DIC with placental abruption and severe preeclampsia. Initial rapid COVID was performed and was negative. Lab abnormalities at presentation included thrombocytopenia, acute kidney injury, mild transaminitis, LDH greater than 600, fibrinogen of 55, and elevated PT and INR. She was transferred to our hospital for a higher level of care where induction of labor was started. The patient had a 12-hour labor course during which her hemoglobin dropped from 10.8 to 5.9. A 75% placental abruption was noted at the time of delivery. Her hospital course was further complicated by postpartum hemorrhage with an estimated blood loss of 2 liters. The patient received multiple blood products during labor and the immediate postpartum, including cryoprecipitate, platelets, FFP, and packed red blood cells. She received magnesium 6 and 2 that lasted for 24 hours postpartum. Throughout her course, she was asymptomatic for preeclampsia, and blood pressure in the postpartum period was normotensive without any antihypertensives. The patient was discharged on postpartum day 3 in clinically stable condition.
On postpartum day 4, the patient presented to our emergency department with a low-grade fever, non-productive cough, and severe range blood pressures. CT angiogram at the time of admission showed left lower lobe pneumonia, and workup for sepsis, DVT, endometritis, and urinary tract infection were all negative. Antibiotics were initiated for treatment of community-acquired pneumonia, and labetalol was also started for blood pressure control. The patient remained febrile despite the use of antibiotics. On hospital day 3, postpartum day 6, the patient's COVID PCR returned positive, and the patient was started on prophylactic Lovenox and also Levaquin for the treatment of suspected superimposed bacterial pneumonia. The patient was discharged home on hospital day 4, postpartum day 7, when she was afebrile for 24 hours. Placental pathology later returned consistent with chorioamnionitis and confirmed placental abruption.
This case occurred in the first few months of the COVID pandemic and was the first instance of severe pre-E possibly caused by COVID that we had seen. Since that time, we've had several similar cases. Since our case report was initially written, a lot of research surrounding the pathophysiology of COVID has come out, so we wanted to briefly review the pathophysiology of COVID and how it could be related to severe preeclampsia. One of the hallmarks of COVID is vascular endothelial damage. Vascular endothelial damage is closely associated with multi-organ dysfunction. The transmembrane serine protease 2 protein on the surface of host endothelial cells interacts with and activates a protein on the viral surface called the S protein. TMPRSS2 also cleaves ACE2 on the host cell surface, which allows ACE2 and the viral S protein to bind. The viral particle is then endocytosed into the host cell, where it replicates and triggers an inflammatory response. The inflammatory response triggered by the virus causes apoptosis of endothelial cells, degrading the endothelial barrier and causing increased vascular permeability with subsequent edema. The breakdown of the endothelial barrier also exposes the prothrombotic subendothelium, where TPA is found, triggering an immune-mediated thrombus formation and an overall hypercoagulable state. So, in short, the COVID virus exploits the ACE2 receptor to enter endothelial cells, where it triggers a response that results in capillary leak and clot formation.
And now to review the pathophysiology of preeclampsia, we do have 2 overlapping theories, the first being underlying maternal cardiac dysfunction. The maternal cardiovascular system requires a transformation to maintain the increased blood volume and cardiac output of pregnancy. In mothers with underlying cardiac conditions such as deconditioning or chronic hypertension, the heart is not able to properly adapt and systolic and diastolic dysfunction occur. As the pregnancy progresses, the demands of the fetus on the maladapted heart outrank the ability of the body to respond. The other theory of the pathophysiology of preeclampsia is poor placentation. Proper placentation requires a complex interplay between decidual natural killer cells and trophoblast cells. NK cells predominate in the decidua and produce cytokines that act as homing beacons to the invading trophoblast cells. Syncytiotrophoblasts in turn downregulate their HLA HLA-A and HLA-B antigens, which natural killer cells are programmed to destroy, and they upregulate the less polymorphic HLA-G that natural killer cells will allow to pass. This process allows the trophoblasts to invade into the decidua and into the lumen of the spiral arteries to effect a remodeling that results in a low resistance vascular system and appropriate flow of blood and nutrients to the fetus. When this interplay is dysregulated, there is shallow invasion and improper modeling of the spiral arteries, and this results in increased vascular resistance and permeability, typically in the third trimester when the fetus demands up to 12% of the maternal cardiac output.
So to discuss where COVID and preeclampsia overlap, the first thing we wanted to go over was the downregulation of ACE2. So the angiotensin converting enzyme 2 cleaves angiotensin to contribute to vasodilation. It's present in multiple tissues, including the lung, kidney, and liver. ACE2 is typically upregulated in pregnancy, but when ACE2 and COVID bind, it results in the downregulation of ACE2 with subsequent vasoconstriction and high blood pressure, like what can also be seen in preeclampsia. High ACE2 expression in the liver and kidney also explains why COVID will preferentially bind and induce endothelial injury in these tissues, leading to acute kidney failure and elevated liver enzymes, which can be seen in both COVID and preeclampsia. The second main mechanism is arteriopathy. As we discussed, the increased vascular permeability and hypercoagulability of COVID is similar to that seen in preeclampsia. Endothelial damage within the placenta from COVID resembles preeclamptic changes histopathologically, and there's evidence that the vascular damage persists after clinical recovery, especially in women with pre-existing cardiovascular conditions, something that's been termed long COVID. Similarly, women who develop preeclampsia are at long-term higher risk of cardiovascular disease. It follows also that vascular damage would predispose women with COVID to placental abruption and DIC, which are known to be associated with preeclampsia.
Now, to briefly review pregnancy outcomes with COVID. Preliminary data does suggest that pregnant women may be more susceptible to morbidity from COVID. Medical complications of COVID in pregnancy have been shown to include sepsis, ARDS, DIC, renal failure, and cardiovascular collapse. Multiple studies have demonstrated pregestational obesity is a risk factor for severe COVID and preeclampsia. Severe COVID is also associated with an increased risk of pregnancy-induced hypertension. However, there was one systematic review that showed no difference in IUFD or neonatal demise between those with and without COVID.
So some topics for future research that we would be interested in related to this would be looking at placental pathology in COVID-19 patients to see what consistencies there are, and also collecting more data on pregnancy complications and outcomes with COVID, since most of the studies so far have been relatively small case controls. Specifically, we would want to look at patients who test positive for COVID but don't require hospitalization for their symptoms, and whether they are also at higher risk of maternal or fetal morbidity.
Thank you.
I would like to thank all the residents for their effort and presentation today. We will now move to our question and answer portion of the program, moderated by Dr. Perry.
And specifically with laboring patients. And mainly the biggest issues were, there was improper use, there was miscommunications between the nursing staff and the residents about what we should use it for, how we should use it, when it should be started, things like that. And ultimately, we thought originally perhaps we needed to do an education source or some sort of maybe like a health stream or some kind of something to provide more education about diabetes and pregnancy and the insulin use in laboring patients. But once we really got down to the problem after asking around, we really found out that the issue was actually with the protocol itself, not necessarily with the education and people's understanding of diabetes and pregnancy. The original protocol was incredibly vague and very unclear wording, which really led to the communication issues we were experiencing and a lot of frustration between all the staff, honestly. And basically, there were several important details that weren't specified in the original protocol, such as like what fluids should be running with the insulin protocol, what really constitutes as a continuous glucose source. And we had a few examples of that if you'd like to provide them. So a couple of things that going off what Marla is saying, the kind of confusion with what is an appropriate glucose source during the insulin drip protocol. The way that it was previously worded, it just said IV, like dextrose, it did not specify dextrose containing IV fluids. It just said, yeah. So in the original protocol, it just said all patients receiving continuous insulin must receive a continuous source of glucose, either via IV at rate greater than or equal to 50, and then in parentheses it says dextrose containing IV fluid or TPN, and then or enteral feeds. And the way that it was worded, there was definitely confusion on the nursing staff side and also the resident side. So the way that I personally interpreted it, for an enteral feed, it's a continuous source, that I wouldn't consider eating PO as a continuous source, because if a patient eats at 8 p.m. and then doesn't eat again until 8 a.m., I would not personally consider that continuous, but on the resident side, they considered that if the patient was tolerating PO, that was appropriate just to have normal saline running with the insulin drip. So that there was a lot of back and forth with what was appropriate and what was the correct way. And then another example, just because it just wasn't very clear, and it's also not included in their order set. I walked into a patient room, and the previous nurse, who was a newer nurse, had started a second IV, which was appropriate, but had no IV fluids running with the drip, just had the drip going by itself, which was at maybe 1 or 2 cc's an hour, so the insulin was getting to the patient because there was nothing running with it. So, I think that because we have a lot of new nurses, we have new residents, things like that can get missed, and it definitely can cause patient safety. And we have a lot of like travel nurses and people like that, so it's a pretty big turnover, I think, on labor and delivery. So really just making our protocol more specific about what to do was ultimately what our project became about. So we already talked about some of the enteral feeds and PO and that sort of thing, and the fluids. The other thing that was causing a bit of an issue was the protocol was being used in what by the old protocol would have been considered inappropriate situations. The protocol itself is specifically for laboring patients. That's the only time we're supposed to use it. However, we had some attendings that wanted to use that particular protocol when patients, like a diabetic patient, comes in and needs steroids, like betamethasone for fetal lung maturity, so they're like preterm labor or something like that. They would order this insulin protocol, and the patient wouldn't necessarily be there for like induction of labor or something, wouldn't be actively laboring, it wouldn't be someone we were trying to deliver. So we also had to clarify that as well. So basically, we met with the nursing staff to identify the problems with the protocol and any of the safety events, like we mentioned, that were stemming from the unclear protocol. And then we sent out a pre-survey to all of the labor and delivery nurses and also high-risk perinatology nurses and the residents to basically just see what their confidence level was using the protocol, any gaps in understanding, and basically identify the best ways to address these issues. And then we had a comment section as well. So we had regular questions and we had a comment section, and most of the comments were related to the fluids not being specified and the PO diet. So once we found that, we basically implemented the changes, updated the protocol, and just changed the wording. We didn't actually change anything necessarily about the protocol itself, but we made the wording more specific. And then we brought the new protocol to nursing huddles. We have 8:30 huddles with the nurses and attendings and residents on the floor. And then we also met with them on our night shift as well. And so during this, so the survey, the pre-survey we sent out, and then maybe the next couple of weeks, we actually updated the protocol based on those results. And then we put the new protocol out for about a month. And so, I don't know, it was probably once a week or so, we would go to the nursing huddles and bring that up to them and make sure everyone had read the new protocol, they were using that when it was ordered. We were talking to the residents about it as well. And then after that, we sent a post-survey after about a month of it being in circulation. And just really to see if there was any, you know, if the changes made things easier on everybody in communication. So the first survey, of course, was there to just really identify any areas for improvement. The questions mainly regarded the fluids, glucose source, the rate of the proper use of the protocol, the rates of insulin, any time of blood glucose checks and things like that. And like I said before, the biggest two issues were with the fluids running and the glucose source. And so we changed the protocol. So as opposed to it just saying as what Lizzie had described before, the protocol now says all patients receiving continuous insulin must receive either a continuous source of glucose via IV at a rate greater than equal to 50 milliliters. Then that in parentheses was D5 half normal saline or TPN, or the patient must be tolerating PO. And then notify the physician if the patient does not have a continuous source of IV glucose ordered, or if the patient is not tolerating PO. So really just specified all of that. And then, so you can see the results of our surveys. So the first one, the one on, I thought you guys is right. Yeah, no, left. Sorry, that's your one. Only about 20% of the people actually got the question right about which IV fluids should be running. The full question asked which IV fluids should be running if the patient is not tolerating PO. And only 28% of people actually picked the D50 half normal saline. After the survey, on the right, you can see about 84% of the people chose the correct answer, and after reading the new protocol. Basically what we can see from this is that most people, they knew that glucose had to be ran with the, should be in the fluids running with the protocol, the insulin protocol, if they weren't tolerating PO, but they didn't really know specific fluids. And honestly, the answer to the first question to the pre-survey would be actually not specified, which is the purple line on the bottom. So a few people got it right, but overall people were just really guessing on the first, on the pre-test. And then the second one, this is the question where we ask what qualifies as a continuous glucose source while maintaining the insulin protocol. What we can really see from this, it was kind of all over the place, but the biggest differences were more people chose TPN and patient tolerating PO than they did before. And then the other, of course, the glucose within the fluids on the other ones would also be correct, depending on the patient and the situation. And then no one chose LR, which is good. But someone did on the first survey. And then more people were able to also get this question correct, which is what are the circumstances that the insulin protocol can be employed? And that's the other communication error where people were really thinking that it could be used for basically any pregnant patient floating around out there. So a lot of people thought it was supposed to be used for treatment of patients in DKA, or, you know, inpatient admission for patients who are really just coming in for control of hyperglycemia and not necessarily in DKA, or coverage for like antenatal steroids. And then the right answer, of course, would be only used in coverage during a labor. And then the next one, you can see people still obviously chose the other answers, but the majority of them chose the correct answer after having read the new survey. And what we really did with that, we didn't actually change the wording on it at all. We really just moved the only to be used during laboring patients. We bolded, underlined it, and put it up at the very top of the chart, and that helped significantly. So basically, the biggest conclusion that came from this was that there wasn't education on either the nurses or the residents' part. Everyone seemed to pretty well understand diabetes in pregnancy and why we had to run an insulin protocol and why we were giving insulin during labor and that sort of thing. After speaking with all the nurses and the residents, it was really just about the protocol itself. Of course, as I was saying before, we had an increase in percentage of respondents that chose the correct fluids after we revised the protocol and after it was released. And then 95% of people identified the correct scenario for implementation of the protocol. But that prior to, so 24 to 34% chose the incorrect scenario, but prior to that, prior to the new protocol coming out, 60 to 80% of people were placing it as the incorrect scenario from the initial survey. And then we had an increase in percentage of respondents who correctly identified appropriate continuous glucose sources. And really it just demonstrated that this changing in wording and formatting really helped with reduce areas of confusion with the protocol. And so, our circulation in the new protocol should hopefully reduce errors in with patient care and really just help with the vague or unclear wording. So of course, we're going to continue to follow this new protocol on the floor because we believe it's going to give us improved outcomes with patients, fewer mistakes, less frustration on staff, on the staff, and really just continue to increase resident and nursing staff exposure to the protocol. I mean, we order this all the time. And I think a lot of it too is the fact that, we basically force people to read the protocol as opposed to just clicking in an Epic and ordering it. So people really knew what was going on. And then, basically just made it more obvious as to what needs to be done. So our special thanks is all of our nurses, everybody from the high-risk perinatal nursing staff and labor and delivery, and of course our OBGYN residents, because those were the people who did our who took our survey. Yes, ma'am.
That concludes our resident presentations. I'd like to give a heartfelt apology for the issues with the audio. I would like to assure that each of the residents that participated and presented their presentations, we will make sure that the judges have access, and they have already been provided access with your abstracts, your submitted slides, your submitted audio, but we will do our very best to rectify the audio issues and in turn provide the judges with that rectified audio so that everybody can be judged on a consistent and fair basis. But we would like to very much thank you for your presentation, your content, and the time that you gave to put these presentations together. I'm going to defer to Dr. Snuffelapati and Dr. Span if they have any questions for our presenters today.
Yes, I put some questions in the chat, but for the person who presented the presentation on ovarian volume, I'd like to clarify why she thought this study was important to do. Presenter number 3.
Yes, that's me. My name's Dr. Graham. So the having unilateral oophorectomies is a fairly common procedure. It's something that we, as OBGYNs, perform very frequently. It has some impacts on fertility, of course. I thought that with, the frequency of this procedure and then the complications later on down the road, such as, considering the hypertrophy that occurs as evidenced, it's important to set some standards for what's normal in terms of ovarian volume after an oophorectomy, and to appropriately counsel patients, who have had a unilateral oophorectomy on potential torsion precautions and things like that. So I think it's important to, prove that this occurs and then examine factors that may impact, whether it occurs and, whether laterality is important.
Thank you. And for presenter number 2, did you perform a sample size calculation?
Yes, sir, we did. An end priority power analysis was performed to give the study 80% to detect an effect size of 1.14 or larger for the breastfeeding self-efficacy scores, which was based on similar studies with a similar design previously. And then based on those calculations, it was determined that only a sample size of 14 per group would be required, but to allow for an attrition rate of up to 20%, a total of 18 participants per group was our target.
Okay, thank you. And what exactly is a Shapiro test?
A Shapiro-Wilkes test is similar to a t-test, except that it is done for groups that do not have normality.
Okay, thank you. And presenter number 1, why was this a cohort study and not a descriptive study?
So the study was looking at the cohort of girls presenting to the ED with these specific complaints in that time, but it was analyzing the rates of torsion based on the scores. So rather than just descriptive statistics of how many of them were torsed or not, it was comparing the score that we calculated for each of these girls, which had not been calculated at the time that they were admitted, and using that to see if it predicted the outcome of torsion.
And tell me some more about the adnexal ratio.
Yeah, so the adnexal ratio is looking at the ratio of the affected adnexa to the unaffected adnexa. The thought being that looking simply at the size of the adnexa doesn't control for the fact that some people may have larger adnexa than the other, but if you expect a torsed ovary to become engorged and enlarged, then evaluating how large it is relative to the baseline size or the size of the other adnexa may be a marker of torsion.
And in your analysis, who was doing the surgery? Was it pediatric surgeons, gynecologists?
The vast majority of the time, these cases were done by the pediatric surgeons. At our hospital, torsion call is covered by pediatric surgery, although pediatric gynecology does exist. So in some cases, they were done by pediatric gynecology if the gynecologists happened to be at the hospital or happened to be available to operate at the time that that case came in. But the vast majority of the emergency calls were to pediatric surgery, which was part of the reason why there was a concern. I apologize, I'm on call. Was one of the reasons why the study was done in the first place, is that often the providers fielding these concerns from the emergency department for possible ovarian torsion are general surgeons or pediatric surgeons and not gynecologists, and therefore may not be quite as comfortable determining who needs to go to the operating room and who doesn't.
And what were these pediatric surgeons doing most of the time? Were they doing cystectomies or were they doing oophorectomies?
It's a range. I'd say there were more than I expected that were simply detorsions and cystectomies, but the overall oophorectomy rate was higher than we would have expected from, say, an adult gynecologist doing torsion. And that was, again, one of the other sort of educational pieces that's tangential to our research project, is trying to make sure that we are emphasizing the value of detorsion and cystectomy rather than oophorectomy to help prevent potential reproductive consequences down the line.
Thank you.
Thank you.
Okay, great. I have a few questions too for the presenters. I'd like to start with those from Augusta University. Oftentimes, the key issue with any initiative like this is the generalizability of the tool. And I noticed that there were a number
Are you there? You seem to have paused just a moment. Maybe your internet went out. Give them a moment to come back to us.
Hello, can anyone hear me?
We can hear you.
Yes.
Okay, I'm so sorry.
If you can repeat that question from the beginning, thank you.
Sure, thank you. Okay, my question is for the presenters from Augusta University. My question regards the generalizability of this application to the general population. Can you please share how many total patients were screened for study involvement and the reasons why they were not eligible?
A total of 156 patients were screened in order to get to our target number of patients. Most patients were just disinterested in participating in a randomized controlled trial and having to follow up with us because those that had initially didn't meet the inclusion criteria were not approached. But then if they ended up having some issue where the baby was in the NICU for too long or mother had to be hospitalized for an extended amount of time and went to the ICU, those were also reasons later on why patients had to be excluded. In this pilot study, that has not happened, but with my current study that is targeting 125 patients, some of those things are already starting to happen.
I guess my main question is that because this was an iOS specific application, how many patients were not allowed to participate because they didn't have iPhones?
Surprisingly, the majority of patients do have an iPhone or an iPad, but there was a small number of patients who were excluded for that reason. Now, if we find that this app is helpful, the goal would be to bring an Android app as well.
My follow-up question for you is regarding your choice to use the breastfeeding self-efficacy scale.
Yes.
And use that to power your primary outcome. How was that choice that you made? How did you decide what's clinically significant? And why didn't you use a more meaningful clinical outcome?
Well, several studies have shown that the breastfeeding self-efficacy is correlated with improved breastfeeding percentages and duration. And so that's why we chose that one for the pilot study. But in the follow-up study, the primary objective is indeed duration of breastfeeding rather than that self-efficacy score, which we're still looking at, but it's a secondary objective at this point.
Great, thank you. My next question is for the presenters from Morehouse School of Medicine. As we know, the ACA was not universally adopted across all states in the union. So I'm wondering, did you look at all at differences in these outcomes related to various states and whether they accepted the federal incentives or not? Anyone from that program available to answer questions? Okay. Let's move on to Mercer University. I did have a question for you. I was very curious as to the premise for laterality. What would be the biological plausibility to even think that there would be a difference in laterality?
So there were some studies that actually have evaluated, ovulation from the left versus the right in terms of fertility. There's also some that demonstrated during our literature review that the left ovary was actually removed more frequently than the right. Our study, found that to be pretty evenly split, but I thought it would be interesting to look at those aspects, considering the potential impacts on fertility that could have.
Did you have a concern that for some reason that one ovary might be larger than the other? I guess I'm trying to get at to why you thought that there would be a difference in size based on laterality.
So I presume that, if the left was being removed more frequently than the right, that it would potentially be larger, in that the hypertrophy, the balance would be potentially different. Didn't turn out that way, but that was kind of the premise.
Great. And I think Dr. Span got to this question a little bit, but how is this information clinically useful?
So it can help in ways with preserving the remaining ovary in patients who've had a unilateral oophorectomy. If we, get an idea or a sense of what's normal versus what's abnormal in terms of size on imaging, it can help preserve that ovary. It also, I think, can help with counseling patients regarding torsion precautions, et cetera, that, hypertrophy can occur and could be, a potential risk factor for, torsion. So just in counseling patients and considering what's normal versus abnormal clinically.
Hey, thank you. I'd like to also.
Dr. Garrett is now able to answer the question for more help.
Okay. Okay, great.
Dr. Garrett, are you available?
Yes, and I was asking previously if he could repeat it because we weren't able to hear.
Well, I was just wondering if you had looked at differences between states that had adopted the federal incentives for Medicaid expansion and those that hadn't.
Unfortunately, I did not look at that, but that is a good note to make, and I will look at that in the future.
Great. And then my next question is for the presenter from Emory. So this is a great study, and I think that the main issue that you identified was that of selection bias. I'm wondering, is there any way that you could have done phase 1 of your study differently to minimize selection bias?
So I think that what we could have done differently with the first arm of the study is what we are doing with the second arm of the study, which instead of just looking at surgically confirmed torsion cases, looking at cases of torsion or presumed non-torsion, that is patients who ended up leaving the emergency department with another diagnosis, whether it be constipation, gastroenteritis, appendicitis, something else that isn't torsion. Because if you're only looking at people who are concerning enough to go to the operating room to get a diagnosis of torsion, then you're already selecting a cohort that's going to have a very high rate of torsion, and that's not really what we're looking at the score to do. So I think that as we started analyzing our initial data, it became abundantly clear that while having a definitive diagnosis of torsion from an operative case was valuable in some degree, that it significantly limited the clinical applicability. And so that was the starting point for planning the second arm of our research, which actually we have now collected that data and are working on analyzing it and submitting it for presentation as well.
That's very good. It was a lot of work to do that first phase, and I was curious why you even did it instead of just going for the second phase to begin with.
Yeah, I think it became clear over time the limitations of our study, and so we made it a dynamic process and continued moving forward. But given that we had already collected so much data from the first cohort, we wanted to sort of share what we had and what we had found so far before moving forward with the next step.
Very good. My next question is for our presenters from Wellstar. I'm curious, how did your experience with this patient and subsequent ones impact your approach to patient care?
No, you go. I think when we experience this patient, moving forward, we always
paid more attention to possible outcomes that could present themselves when we did have a patient who presented during being COVID positive. Again, this happened at the very beginning of the pandemic. So, when we had this experience, it kind of guided our care and being very careful and being very aware of the complications that could occur when patients would come in being COVID positive again in the future.
An overall higher index of suspicion for similar patients.
Okay, very good. And I think there's no one available to answer questions from Savannah. Is that correct?
That's correct.
Okay, well, that concludes all my questions.
I have one more question for the Augusta group. Will you include telephone contact, i.e. calling the patients to see how well they're doing with their breastfeeding?
Yes, we did include telephone contact. That is how all of the initial surveys were actually completed. And then, or most of them at least, besides a 6-week postpartum visit. And of course, now that I'm following people up to 6 months, we are contacting them any which way that we can via Qualtrics surveys, email, text, telephone calls.
And one last comment to the contraceptive group, the persons that did the contraceptive study. The number one problem in the world, I think, is overpopulation. So for you residents, I hope you guys consider fellowships in family planning. I think it's the biggest problem we face as a world. Thank you.
With that, I see a single question in the chat box, particularly for you, Dr. Garrett. That was a good segue. And it asked, are you aware of whether there has been a notable reduction in the birth rate given the increase in LARC methods? Just wondering if you have any response or any.
One more time.
Okay. Are you aware of whether there has been a notable reduction in the birth rate given the increase in utilization of LARC methods?
I did not see or look at that association with birth rate as it pertains to contraceptive use, but honestly, that is another great question that I'll look into. Thank you.
I think we're designing the next arm of your
You are, and I think that's great. And I know that there was plenty of other questions that related to this one particular research question that we looked at. And so all these ideas that y'all are throwing out are very helpful and very useful. Thank you.
We really also appreciate the Savannah Memorial Group, or the HCA now group. Our presenters are actually on night float right now. So we respect the fact that they're asleep right now and can't be with us, but thank you for their presentation equally. Again, I apologize for the audio difficulties. We'll try to get those rectified. And remember that we will have all the presentations available for on demand. And we'll do our very best to make sure that you can have that good audio quality when you check back in for on demand. I appreciate all our presenters. I appreciate their faculty supporters. I very much appreciate our judges and their time today. And thank you so much for the folks who tuned in today. I hope the residents see that there is support for you. We're very interested in having this new generation of residents become active in our state in terms of education, advocacy, and all the rest. And we think you can find that with us at the Georgia OBGYN Society. And we hope that you are, if you're not all members already, that you'll think about becoming members. We'd love to have you. And we have a great time at our yearly annual meeting in August every year. So we would love to see your faces there. You can always present again, and we'd love to hear more from your work. Thank you for the folks who positive questions. We'll get back to anybody that comes up with questions after the fact. I'd like to remind everybody about our last lunchtime lecture, which will be next Tuesday. The time is a bit different from our previous lectures. It'll be from 6 p.m. to 7 p.m. And we'll have Dr. Andrea Braden from Emory School of Medicine who'll present supporting lactation challenges and best practices. I'll look forward to seeing everybody then. Thanks for being with us today.